Thank you very much.
Thank you very much, Professor Chenchi, for excellent presentation. Can I remind the audience to please, if you have questions, send them through the Q&A function on your Zoom screen, not through the chat line, through the Q&A function down the bottom of your screen. It gives me great pleasure to introduce our next speaker, Mr. Andy Williams from the Fortius Clinic in London. He had very extensive experience in the management of elite athletes and has done some excellent research in the area of ACL and lateral stabilization, and that's what he'll be talking to us today. Thank you, Andy.
Thanks very much, David. Welcome, everybody. There is a number of facts, a number of myths regarding ACL surgery, and I want to focus on a few of these today. We're not as good as we think we are at controlling the pivot shift, and after all, the pivot shift is the goal of ACL reconstruction. There are multiple studies that have shown that there are ineffective procedures, even if patients are asymptomatic. And so we got interested in trying to improve things. So the first part of the talk really illustrates the problem. These diagrams show a large orange oval, which represent the top of the tibia, and a small one, the fibula. The grey circle is the center of axial rotation, slightly in the medial compartment of the tibiofemoral joint. If you look at the alignment of the ACL, it's perfectly aligned to control anterior tibial translation. But if you look at its alignment with regard to controlling rotation, it has a very short lever arm. And so if you put a graft in place, it has to work very hard. If you compare that with a structure or an operation on the lateral side of the knee, and this is a very powerful way of controlling rotation, as its lever arm is enormous. So we got interested in the lateral side of the knee. We published a review article in 2011. We started dissecting knees, and there's a picture from our publication on the right. Little did we know that the group in Leuven in Belgium were doing exactly the same thing, and they published effectively the same ligament that we had described, but they were 3 months earlier in November 2013. Alex Dodds published the first paper from our group, and he was replaced by Christoph Kittel. And Christoph was set about to research the ALL. But very quickly, he realized that there was a big contribution from the IT band. Now, I realize that this video isn't working particularly well at the moment. It's rather jerky, so I'll just take you through it. This is a dissection of the IT band you can see here, and it's been taken off the front of the knee and reflected posteriorly. And that's left the posterior portion of the IT band intact. And you can clearly see how it attaches with strong fibers and attachment sites on the lateral tibia, the so-called Kaplan's fibers here and here. And you can see a band of tissue running from Gerdy's tubercle straight up along the posterior IT band to the femur. This is a very robust, large structure. It's present in everybody. In our study of the ALL, we can only find it in 4 to 5 cases, and it's a very small structure in most cases. The work that Christoph then continued to do was to study the various structures in the lateral soft tissues. And the first thing he found was that the ALL really is not an important structure at all. At 0 degrees, the ACL is the most important controller of internal rotation or a simulated pivot shift. At 30, 60, and 90 degrees, however, we were surprised to find in our laboratory experiments that it's the IT band that you saw in that previous video going from Gerdy's tubercle to Kaplan's fibers that's the main restraint to internal tibial rotation and the simulated pivot shift. Now, you will have read a number of papers saying that the ALL is important, but if you look at those papers in detail and don't just read the abstract, you'll realize that the studies are often fundamentally flawed. This one, for example, that's frequently cited to prove the ALL is important, involved removing the IT band before the experiment started. And so if you remove the most important structure, all you're left with is tissue that's not important, and then a little bit of unimportant tissue suddenly becomes important. So the study designs are often flawed, as I said. Christoph Kittel finished up. He was replaced by Ivan Interhaug in our lab as the fellow, and he's published a number of studies, but I'll summarize them in the next couple of slides. Firstly, he found that the lateral extra-articular tenodesis is much more effective than ALL reconstruction, and multiple studies he undertook. He also found that a tenodesis graft needs to be taken deep to the LCL to work properly. And if you do an ALL reconstruction, then you have to tension it at 0 degrees. because it's very non-isometric, whereas a modified Lemaire technique can be tensioned at 0, 30 and 60 degrees. It's pretty obvious when you look at these images as to why the tenodesis is more effective than an ALL reconstruction. You can see the rather low angle of a tenodesis, and if you compare this with a ALL reconstruction or the ALL itself, which is much more vertical, you can see why a tenodesis wins every time. Now, one of the criticisms of a tenodesis is that it's very non-anatomic. Well, there's truth in that. We take a graft of the IT band deep to the LCL, which clearly is not an anatomic passage for that tissue. But if you look at this dissection from Elmer Herbst when he was a fellow of Freddie Fu, there is perhaps a clue as to why taking the graft deep to the LCL is helpful. If you see the posterior IT band from Gerdy's tubercle passing up to the distal femur at Kaplan's fibers, you'll notice it follows a curvilinear path. And with a straight graft, we can't achieve that unless we take it deep to the LCL, which acts like a pulley and allows us to reproduce that curvilinear passage of tissue. And so although it's certainly not anatomic, it may be the best anatomic compromise. Another criticism of tenodesis is that it causes overconstraint. Well, those who use that phrase are trying to imply that it'll cause osteoarthritis, but they never actually say what they mean by overconstraint, because some constraint is needed for the thing to work. Do they mean that you lose a little bit of terminal internal rotation? Well, I'm not sure that's a problem. Many of my patients are professional footballers, and when they shoot for goal, they maximally internally rotate their leg below the knee. And if there was a problem with that, I'm sure they would tell me. Does it mean loss of flexion? That doesn't seem to happen. Do they mean that the operation causes increased articular contact pressures or a fixed external rotational deformity? Because if that happens, then that really would be a problem. We've learned that from shoulder surgery. Now, Ivan studied this in detail, and importantly, you must note it is possible to overconstrain and cause increased articular contact pressures in the joint, and he's published on that. If the graft has an excess tension of 40 newtons, or the tibia is fixed in external rotation, this is a bad thing. So you need to think of the tenodesis graft as simply a check rein, like an MPFL reconstruction, and just take up the tension in it. Only 20 newtons is enough. And when you fix the graft to the femur, make sure that the knee is in neutral rotation. So in other words, 10 degrees external rotation, because otherwise you will overconstrain. Now, overconstraint is also possible with ALL reconstruction. You have to tension it with the knee straight, but also all of the experiments that show it works have had to really give excess tension. Rob LaPrade's study to show an effect of the ALL reconstruction used 96 newtons, which is a lot of force. And because it's so vertical, you have to really tighten it up too much. And shown that I've published evidence of damaging overconstraint. Now, of course, lab studies are weak in some ways, and whilst they're important, they're not the whole story. And so clinical studies are really important. I did a one-year follow-up as a minimum on my cases, a due diligence, and didn't find any loss of flexion or extension. And I found that the abnormal pivot shifts reduced from 9% to 2%. A far more powerful study is recently published by Al Getgood, which won the O'Donoghue Prize last year at the ASM. And he found that the re-rupture rates fell from 11% with an ACL reconstruction alone in high-risk cases to only 4%. There's also some encouraging evidence that tenodeses don't cause osteoarthritis from a meta-analysis from Brian Devitt from Melbourne, and also from Henri Dejour's patients at a minimum 20-year follow-up published a few years ago in the AJSM. But clearly the clinical work needs to continue as a proper due diligence of what we'll be doing. So I must acknowledge all the work of those in the lab, as you can see listed here under the guidance of Andreas, and these are my disclosures. Thank you very much indeed.
Thank you very much, Andy. Right, it's a very hot topic, right, which is important. We'll leave the Q&A later on, right? So, Bancha, are you ready? Right. So we are going to introduce the next speaker. Is Dr.Bancha Chachuji from Thailand. He's a professor in orthopedic surgery, Faculty of Medicine, Thammasat University of Thailand, right? So he's going to give a talk on the how to deal with shock graft, shock tunnel in ACL reconstructions among Asian people, which is a very, very common problems in Asia. So Bancha,
yes,
are you ready?
Hi, I'm
Good.
ready.
Thank you.